Now we're turning to hope in action through the collaboration of NET specialists. You will learn more about treatment sequencing, always a popular discussion, and see a tumor board where NET specialists consider treatments to develop a plan for a patient. Our co-chair, Dr. Xavier Keutgen, and his University of Chicago Medicine colleagues, Dr. Andy Liao and Dr. Ahmed, will discuss combining and sequencing novel therapies. Then for the tumor board, they will be joined by NET specialists, Dr. Mark Lewis, Director of GI Oncology at Intermountain Health and a NETRF board member, Dr. Heloisa Suarez, leader of the NET program at Huntsman Cancer Center at the University of Utah, and Dr. Aman Chauhan of the University of Miami.
Good afternoon and good morning, everyone, wherever you are, and thank you very much for joining the NETRF virtual conference. I will talk to you today about treatment sequencing, and in particular, I will talk to you about the role of surgery and PRT in the treatment sequencing of neuroendocrine tumors. So these are the NCCN guidelines from 2018, but they haven't changed significantly. These guidelines are used by clinicians, and as you can see here, patients with metastatic neuroendocrine tumors, if complete resection can be achieved, as you can see here, that is the recommendation and it should be done. However, things get a lot more complicated when complete resection cannot be done surgically. First-line therapy is usually long-acting octreotide, and then patients eventually progress on this therapy, and then you have a whole long list of all kinds of different systemic as well as local regional therapies. And you can see here the NCCN guidelines say or. So really it's unclear what needs to be done first, and depending on what center you are and specifically from one patient to another, the recommendations may change. Therefore, it's important to really try to understand what therapy is better for what patients. Systemic therapies that comprise long-acting octreotide as first-line therapy, but also targeted chemotherapy, and PRT are really an important milestone and a cornerstone of metastatic neuroendocrine tumor care. But local regional therapies like surgical debulking, liver-directed therapies with bland embo, radio-embo, or chemo-embo, as well as liver transplant, albeit that's pretty rarely, are also very important. What therapy to use when? Really depends on multiple things, including overall tumor burden, tumor distribution, patient wishes, symptoms, and comorbidity, and also access to therapies. So if the tumor is mostly limited in the liver, but it's not too much tumor, surgical debulking can be offered. This is mostly in the skeleton. Surgery probably is not the best option, so probably a systemic therapy would be better. And then not every patient has access to a high-volume surgical debulking center, experienced IR doctors, or even PRT in certain regions, although that's getting better and better. I want to talk to you today specifically about PRT and surgical resection and debulking, and try to explore the relationship between these two therapies and how they can help each other. So metastatic pancreatic neuroendocrine tumors, or as a matter of fact, all neuroendocrine tumors, are often metastatic to the liver. You can see here about 50% of both PNETs and small bowel nets. And as you can see here in that graph, overall tumor burden plays an important role, especially liver tumor burden in terms of survival. So if you have greater than 50% of your liver that's replaced with tumor, your survival is significantly worse than if you have less than 10% of your liver that's replaced with tumor. The number 1 and 2 causes of death in neuroendocrine tumor patients are liver failure due to overwhelming liver tumor burden. So that's a majority of cases. And then some people get into complications and potentially deadly complications from primary tumors, especially when it's designed as small bowel like obstruction, perforation, or bleeding. Now, you've seen me talk about this before, but why do we offer surgery for liver metastases? And why do we do surgical debulking? Well, surgery is the only potential for cure, although that happens rarely when you have liver metastases, so the tumor is spread outside of the vicinity of the primary tumor. It is quite difficult to cure patients because even if we take out everything that we see within the liver, there still is a chance of recurrence through micrometastatic disease. So what we can't see, we can't remove. But We have a handful of patients certainly that have been cured. If there really only are a few lesions in the liver and there's nothing else, removing them can cure you, which is why the NCCN guidelines recommend to do that. There's a survival advantage over neurosurgery in retrospective studies. So by resetting the clock, so removing most of the disease, greater than 90 or 95% most of the time, because these are slow-growing tumors, we sort of allow many years until the tumor grows again to the same size than it was before surgery. So that gives you effectively years in your life bank. Surgical debulking definitely improves symptoms. There's no question about this. And I'll invite you to look at our tumor board that we are going to present later during this NETRF session as well. And you'll hear about some of these cases. And we can achieve major tumor burden removal with surgery, which is usually not the case with systemic therapy or even liver-directed therapies that are non-surgical. And then complications are much decreased, especially in high-volume centers, as we get better and better at doing these cases. Lastly, surgery may make systemic therapies work better, and this is the loop back to PRT that I'll talk to you about in a few minutes. So you've also seen this maybe before, but we look at where tumors are within the liver. Are they on both sides or on one side, uni or bilobar? Here, the tumors are in dark. We look at the relationships of these tumors to inflow and outflow, and we look at individual tumor size in order to understand how we do the resections, but we always try to cut just the tumors out or to ablate them without taking major structures, inflow, outflow, or major parts of the liver in order to prevent complications in liver failure. There are cases where we definitely don't want to operate, so it's important to know when to operate and when not to operate. Those are when you have a lot of liver tumor burden, when you have bad carcinoid heart disease that usually needs to be fixed first before you take patients to the operating room for the liver, portal vein thrombosis, poor performance status in highly aggressive tumors like G3 tumors or polydifferentiated neuroendocrine carcinomas are generally not good candidates for a resection. And many studies, all retrospective, over thousands of patients have shown that surgery can be done, that it can be done well. This is our series that was published last year, and we showed that the rate of complication is less than 15%, the major rate of complications, and that the liver function can completely be preserved after these type of cases. That's on the right side here. Specifically, the one thing that we noticed mostly is the more tumors you debulk, in this case greater than 25 in purple, the lower your platelet count drops within the first few days, but that, as you can see here, recovers relatively quickly within 5 days. It's true also for the liver damaging enzymes like ALT and AST. You can see they spike up the more you resect, but then they normalize within 5 days. So liver failure is not a problem with these type of operations if it's well done, and patients recover very well with low rates of complications. We even have shown in the past that if you have surgical debulking, when you have extrahepatic metastases, so let's say skeletal metastases, you can see here the dark curve here shows that we still actually have an improvement in overall survival compared to no surgery, which is the blue curve. But it's not quite as good if you have extrahepatic metastasis than if you don't, which is the green curve. But let's not kid ourselves and let's be honest, right? All of the surgical debulking data that I showed you is retrospective, meaning there's no comparative studies that basically compares surgical treatment to another treatment. So even though it's definitely beneficial, we think we don't know how much better it is than any other therapies. The truth is also that surgical debulking does require a certain expertise and generally is only available within multidisciplinary centers. So some patients may not necessarily get access to it, or their disease may have progressed too far along without them having the opportunity to see a surgeon. And therefore, once they see a surgeon, there may be too much tumor burden in the liver to be debulked. And then the sequencing of when to use surgical debulking, especially when compared to other therapies, really remains unknown. And this is why it's so important to continue to study this field, even though surgery has been used for a long time. And especially it's important to study surgery in relationship to other therapies. And one of these other therapies is PRT, right? So theragnostics stands for therapy and diagnostics. You've heard about this. It's essentially the principle of using a targeted molecule with a linker and a medical radioisotope to either make things light up for diagnosis or to destroy it when you have beta or alpha particle that are combined with these targeting molecules that then targets the tumor cells directly. The oldest form of theragnostics is actually radioactive iodine, which has been used for thyroid cancer for over 60 years. And you know that somatostatin receptors are expressed in well-differentiated neuroendocrine tumors and therefore represent an ideal surface molecule for theragnostics or PRRT to work. And Lutathera, which is a beta-emitting theragnostics that we use all the time, actually is comprised of either gallium or copper-64, 68 for diagnosis, or lutetium-177, the beta-emitting particle that you can see here in the chelator area. And then we have the DOTA, which is really the linker that links the chelating area to basically octreotide that then targets the somatostatin receptor on the cell surface. And PRT has basically, as you know, been shown in the NETRF and recently in the NETRF trial, which Dr. Liao talked about, to significantly improve progression-free survival. But even though injected 4 times, total of 800 millicuries over 8 months, it is certainly not curative. And if you look at this European data here, you can see that the partial response or complete responses are still less than 50% in most cases. Pancreatic neuroendocrine tumors tend to have a little bit higher rates of response, and this is one of the things that my lab has been studying. And without going into too much detail, what we essentially showed is that MEN1, which is a common mutation in pancreatic neuroendocrine tumors, actually predisposes a more radiosensitive phenotype. So those cells actually cannot repair DNA as well because they have a defect because of the MEN1 loss of function into the DNA repair capabilities, and therefore radiation, like beta-emitting radiation given with PRT, makes these cells die more rapidly. And we've seen this recently in a study that's not being published, but will be published very soon, where you could see here, we compared MEN1, DAX, and ATRX mutant tumors. They are all involved in DNA repair, these 3 genes, in the blue line. And then the wild type, so those without a mutation, in the red line. These are all patients that underwent PRT. And you can see that those with the blue line, so that had these mutations, tend to have a longer progression-free survival, especially when you look at pancreatic neuroendocrine tumors here, which is the second graph. You can see over 20 months difference in terms of progression-free survival. So PRT works better if you have these mutations. Now, when we look at overall what has been known about all these systemic therapies that we use for patients with metastatic neuroendocrine tumors, especially to the liver, very few actually give us information on how well they work with liver disease. And remember, liver disease is very important in terms of prognosis long-term for metastatic neuroendocrine tumor patients. And so really, we ought to study further how these therapies can work in order to stabilize and possibly decrease the liver tumor burden. Now, there is a little bit of data from the NETRF trial and a sub-analysis that has shown that Lutathera, so PRT, works better when you have smaller tumors that are less than 3 centimeters within the liver. And there's also European studies that has shown that if you resect the primary tumor in those patients that undergo PRT, those patients actually tend to do better and live longer. So at the University of Chicago, we recently studied specifically this question is, does surgical debulking improve responses to PRT? I showed you that MEN1, which is something that we can't change, either your tumor has a MEN1 mutation or it doesn't, improves progression-free survival after PRT. But is there something we can actually do to make these progression-free survival curves better? And this is a manuscript that's been accepted and will be published very shortly. So here we looked at almost 100 patients, of which a third did not undergo surgery and 2/3 underwent surgery. About 43% had only their primary tumor removed, and 57% had surgical debulking of the liver in addition to their primary tumor. And as you can see here, those that had the primary tumor resection versus those that didn't have surgery, the progression-free survival after PRT, so all these patients had PRT, was not really significantly different. It was just a few months better. But when we looked at those that underwent surgery versus those surgical debulking versus those that didn't, you can see here that the progression-free survival after PRT is greater than 1 year. So you gain 1 year after PRT or more in those patients that underwent surgical debulking. When we ask our question why that is, we started calculating tumor volumes before PRT in the surgery and the no surgery group. And we found, thank God, as a surgeon, I have to say, that the tumor volumes in the surgical group were significantly lower, as you can see here in blue here in the right lower corner, compared to those that did not undergo surgery. So meaning we removed a bunch of tumor when we actually did the operation. But when we looked at the graph, we identified 138 milliliters as sort of the ideal tumor volume in this particular study that made the biggest difference in terms of survival after PRT treatment. So those with a lower tumor volume that underwent PRT had almost 21 months, so almost 2 years, benefit after receiving PRT than those that had a higher tumor volume. So we therefore concluded that probably surgical debulking decreases tumor volume and therefore improves the response rate to PRT. So when we talk about the sequencing, we think that perhaps surgical debulking should happen prior to PRT rather than after, because it would allow PRT to work better with a lower and smaller tumor volume. So in conclusions, we showed recently that research is really important to identify variables that predict PRT response. I showed you a little bit about the MEN1 mutation status that we showed in the lab and then confirmed in our clinical cohort. We also showed that patients with metastatic neuroendocrine tumors may benefit from tumor reduction prior to undergoing PRT. And then we also showed that reliable prediction calculator for PRT can probably be developed. We're going to work on this over the next year. And that PRT calculator may include pathologic variables, somatostatin receptor expression, but also genomic things like MEN1 mutations, DAX, ATRX mutation, and also volumetric variables, lower volume versus higher volume. And the ideal situation would be that in the future, you have as clinician, we have a website where we can put all kinds of variables and then we can know, how well you're going to respond to PRT and whether PRT, therefore, is the next best solution for you or whether another systemic therapy may be better. So surgical debulking definitely may complement PRT rather than compete with it. And therefore, we conclude that surgical debulking and systemic therapy, in particular PRT, and we're studying other systemic therapies at this point as well, are really going hand in hand. It's not one versus the other. It's really trying to understand those patients that can undergo debulking, should undergo debulking, but when should it happen? And we think that at this time, at least with the data I've showed you, it's better that it happened earlier in the course before PRT happens than later. So with this, I'd like to thank you and NETRF and all these associations and foundations that have funded some of this research, as well as my collaborators. This has been really an exciting few years for us. I think research is really taking off all across the country and the world, and NETRF has really played a hugely important role in making sure that this research happens. So thank you very much to NETRF, and thank you to all of you for being part of this meeting today, and I hope to see you soon.
Hi everyone, I'm Andy Liao from the University of Chicago. Today I'll be talking about combining and sequencing novel therapies in neuroendocrine tumors with an emphasis on systemic therapies. We'll start by talking about the evolving role of lutetium dotatate PRRT, which is Lutathera, including data supporting its use in first-line therapy, as well as the optimal sequencing and combination approaches for PRT. We'll then talk about alpha PRT, and finally, novel targeted therapies with a focus on cabozantinib. So when we think about systemic therapies for well-differentiated neuroendocrine tumors, we're talking about somatostatin analogs, which include octreotide and lanreotide, PRRT, which includes lutetium dotatate or Lutathera, or alpha particle PRRT. Targeted therapies, which include everolimus, sunitinib, and cabozantinib, and then traditional cytotoxic chemotherapy, which includes capecitabine and temozolomide. And in today's talk, we'll go over the data that informs us how to sequence all of these treatment options or perhaps combine them in the treatment journey for neuroendocrine tumors. We'll start by talking about the evolving role of lutetium dotatate PRRT. So as you know, lutetium dotatate, or Lutathera, PRRT is the cornerstone of systemic therapy for neuroendocrine tumors. Shown here are the results of the NETRF study, which is the study that got Lutathera approved in our country. This study took patients with well-differentiated advanced mid-gut neuroendocrine tumors that progressed on previous somatostatin analog therapy, randomized them to getting Lutathera compared to high-dose octreotide. And it's shown that lutetium dotatate led to a significantly improved progression-free survival of 28.4 months compared to 8.5 months in the control group. The hazard ratio was 0.21, so 79% reduction in the risk of progression or death with lutetium dotatate. The response rate was also better, 18% with lutetium dotatate compared to 3% with the control group. And there was also a trend toward improved overall survival, 48 months compared to 36 months in the control group. And so as a result of this data, lutetium dotatate is approved for second-line treatment for patients with advanced neuroendocrine tumors of GI origin. And now we're going to look at data that supports the use of lutetium dotatate in the first-line setting. So we'll be talking about data from the phase 3 NETRF study. This is a study that enrolled 226 patients with advanced well-differentiated neuroendocrine tumor. The tumors are grade 2 or grade 3 with the Ki-67 of 10 to 55%. And these patients are treatment naive, have never received any systemic therapy. The patients were randomized in a 2-to-1 fashion to getting lutetium dotatate compared to the control arm of high-dose octreotide LAR. And at the time of disease progression, they were allowed to cross over. I wanted to show you the patient demographics. So in this study, about 2/3 of the patients had grade 2 disease, whereas 1/3 of the patient had grade 3 disease. The Ki-67 range was 10 to 50%, with the median of 17%. So here are the results of the NETRF study. So lutetium dotatate in the first-line setting in the grade 2 and grade 3 NET population showed a progression-free survival of 22.8 months compared to 8.5 months in the control group. The hazard ratio was 0.28, meaning that lutetium dotatate in the first-line setting led to a 72% reduction in the risk of progression or death compared to the control group. The response rate was also significantly higher, 43% with lutetium dotatate versus 9% with the control group. And it's also been shown that there's no new safety signals with lutetium dotatate used in the first-line setting in this population, and that the quality of life was similar in both arms. And so my take-home points are that lutetium dotatate significantly improves progression-free survival for patients with well-differentiated grade 2 and grade 3 neuroendocrine tumor with a Ki-67 of 10 to 55% in the first-line setting. But does this mean that we should use PRRT first-line for everyone? Well, not necessarily, because there's no overall survival data yet to suggest that this will overall help people live longer. There's also many long-term toxicities of PRRT to consider, including myelodysplastic syndrome and others. And there's also many other great treatment options for neuroendocrine tumors, including surgical debulking and liver-directed therapies and other novel systemic therapies. So in other words, this is a marathon and not a sprint. And just because you start out running faster in a marathon doesn't mean you're going to come out ahead. So now we'll go over some data that informs our sequencing of lutetium dotatate in the treatment journey. So this is our own data from the University of Chicago. So it's a retrospective analysis of patients who received PRRT and Keutgen and seeing which one is better. So we took 59 patients in our analysis, and we look at the progression-free survival of patients who got PRRT versus Keutgen. So the median progression-free survival was 21.9 months for PRRT and 20 months for Keutgen, but it was not statistically significantly different. So overall, there's no significant difference in progression-free survival, response rate, or overall survival in our analysis. However, if we look at subgroup analysis, it seems that the progression-free survival was improved with Keutgen in patients with grade 3 disease. So with Keutgen, it was 16 months compared to 8 months for PRRT. And the PFS was improved with PRRT in tumors that have mutations in MEN1, DAX, and ATRX. So in this instance, the PFS was 28 months with PRRT compared to 19 months with Keutgen. And so perhaps for patients with grade 3 disease, we want to start out with CAPE-10. And for patients whose tumors have mutations in MEN1, DAX, and ATRX, we may want to use PRRT first. We also showed that CAPE-10 produced a faster time to response than PRRT. So the time to response was 6 months with CAPE-10 compared to 11 months with PRRT. Therefore, for patients with large tumor burden, very bulky disease, or very symptomatic disease, or rapidly progressing disease, or patients who we're trying to induce rapid tumor shrinkage to get them to become a surgical candidate, these may be patients who are ideal for starting off with CAPE-10 as opposed to PRRT. And of course, this was a retrospective study, which is fraught with all the limitations of a retrospective study. And so we need prospective clinical trials to help us answer the question, which one is better to start off with. So this is a phase 2 compare-NET study that's currently enrolling for advanced well-differentiated pancreatic neuroendocrine tumors, starting with lutetium dotatate compared to capecitabine and temozolomide. Here are some of the other studies that are trying to answer the treatment sequencing question for PRRT. So this includes the phase 3 COMPETE study of lutetium edotriotide PRRT versus everolimus in grade 1 and grade 2 GEP-NETs, and the phase 3 COMPOSE study of lutetium edotriotide PRRT versus the physician choice of best standard of care for grade 2 and grade 3 GEP-NETs, and in this instance, the best standard of care includes everolimus, CAPE-10, or FOLFOX chemotherapy. So now we move on to some of the data looking at combination approaches with lutetium dotatate. So PRRT and CAPE-10 are both very effective treatments for neuroendocrine tumors. So what does this data look like if we combine them? We're going to look at the data from the phase 2 control-NET study. So this is one of the cohorts of the study that enrolled patients with advanced grade 1 and grade 2 mid-gut neuroendocrine tumors, randomized them in a 2-to-1 fashion to getting PRRT plus CAPE-10 combination therapy versus the control arm of PRRT alone. So there were 32 patients in the combination group, 13 patients in the PRRT control group. So I've shown the data here in the table. As you can see in the combination group, the response rate was 34% compared to 23% in the PRRT alone group. But the progression-free survival rate at 36 months was very similar. It was not significantly different. It was 60 and 61%. However, the combination group had a significantly higher rate of grade 3 and grade 4 toxicity. So the rate was 88% in the combination group compared to 46% in the PRRT group. In terms of long-term hematologic adverse events, it was 13% with the combination group and 31% with the monotherapy group. So my take home, at least for the data for this cohort for mid-gut neuroendocrine tumors, is that the combination therapy maybe led to a slight improvement in response rate, but really no difference in progression-free survival, but the combination therapy was significantly more toxic. The same study also had a different cohort with pancreatic neuroendocrine tumor, grade 1 and grade 2. These patients are randomized in a 2-to-1 fashion to getting combination of PRRT and CAPE-10 versus the control arm of CAPE-10 alone. So 18 patients were enrolled in the combination group and 9 patients in the CAPE-10 alone group. So shown here in the table are the data. So the combination group led to a response rate of 72% compared to 33% with capecitabine and temozolomide alone. And the 27-month progression-free survival rate was also significantly higher, was 61% with combination therapy compared to 33% with CAPE-10. In terms of long-term hematologic adverse events, it was 17% with the combination group and 0% with CAPE-10 alone. So in the pancreatic neuroendocrine tumor cohort, at least for this study, it seems that the combination therapy definitely led to improved clinical outcomes, although also more toxicity, and may warrant further study in follow-up larger phase 3 trials. Here are some of the ongoing PRRT combination trials. So this includes combination of PRRT with triampine, which is a ribonucleotide reductase inhibitor, combining PRRT with olaparib, which is a PARP inhibitor, and then combining PRRT with M3814, which is a DNA PK inhibitor. So now we're going to switch gears to talk about alpha particle PRRT. So what is alpha particle PRRT? Well, this is PRRT that uses alpha particles such as actinium and lead, as opposed to traditional PRRT that we have available using lutetium, which is a beta particle. So alpha particles have a shorter range and therefore allows for more selective targeting of the tumor cells while sparing the healthy surrounding tissue. There's also higher linear energy transfer compared to beta emitters, leading to complex DNA double-stranded breaks. So scientifically and theoretically, alpha PRT would be better than beta PRT. However, what does the clinical data show and how does this inform our treatment sequencing? So recently presented at our ASCO annual meeting is the data from the phase 1 and phase 2 Alpha Medics 01 and 02 trials looking at alpha PRT with lead dotamtate in patients with PRT naive GEP-NETs. So the combined analysis included 44 patients who got lead dotamtate. The response rate was 56.8%. The 24-month progression-free survival rate was 74.3%, and then the 24-month survival rate was 90.7%. Shown in the picture on the bottom left are 2 patients who responded very well to this alpha PRT therapy. In terms of toxicity profile, there was no substantial hematologic toxicity. They did see grade 3 or grade 4 lymphopenia, but that was mostly reversible. They also saw mild to moderate alopecia, which is transient, and then they saw dysphagia, which is difficulty in swallowing from achalasia, so it seems like somehow this treatment is affecting the motility of the esophagus. So these are definitely encouraging initial clinical trial results. I'm definitely eagerly awaiting the results from the other cohort of patients in these trials who have been previously treated with beta particle PRT to see what is the activity of alpha PRT post-progression on conventional PRT. And in the future, we probably will see randomized trials to help us answer the question whether we should start with alpha PRT instead of conventional PRT, or whether we should save alpha PRT upon progression on conventional PRT. So now we're going to move on to talk about targeted therapies with a focus on cabozantinib. So just as a reminder, this is the current treatment landscape for targeted therapies in well-differentiated neuroendocrine tumors. So for pancreatic neuroendocrine tumors, we have everolimus and sunitinib as the FDA-approved options. And for other GI and lung neuroendocrine tumors, we have everolimus. Cabozantinib is a targeted therapy drug that targets VEGF, MET, AXL, among many other pathways. So these are pathways that affect the tumor cell's motility and invasion, affects how they make new blood vessels, and affects how the tumor cells hide from the immune system. So recently there was positive data presented from the phase 3 CABINET trial for cabozantinib in neuroendocrine tumors. So this study took 290 patients with advanced, well and moderately differentiated neuroendocrine tumors, randomized them in a 2-to-1 fashion to getting cabozantinib compared to placebo, with crossover allowed at disease progression. So let's first look at the cohort of patients with extrapancreatic neuroendocrine tumors. So there were 197 patients in this cohort. I want to point out that the median time from diagnosis to enrollment in the trial was 87 months. So in other words, 7 years into the patient's treatment journey. The median numbers of prior lines of systemic therapy was 2, but ranged from 1 to 7. So in other words, this was a heavily pretreated population. This study also included patients with well-differentiated grade 3 disease, so about 6 to 9% of patients. So here are the results for the extrapancreatic neuroendocrine tumor cohort. So the median progression-free survival was 8.3 months with cabozantinib compared to 3.2 months with the placebo group. The response rate was low, was 4% for cabozantinib and 1% with placebo, and the survival was not significantly different. And now we'll look at the cohort of patients with pancreatic neuroendocrine tumors. There were 93 patients in this cohort. So again, this was a heavily pretreated population. The median time from diagnosis to enrollment was 84 months, so 7 years into the treatment journey. And the median number of lines of prior systemic therapy was 3, with a range from 1 to 9 in the cabozantinib group. This cohort also included patients with well-differentiated grade 3 disease, so 10% of patients had well-differentiated grade 3 disease. So here are the results for the pancreatic neuroendocrine tumor cohort. So cabozantinib led to a median progression-free survival of 11.4 months compared to 3 months in the placebo group, with a hazard ratio of 0.67, meaning a 33% reduction in the risk of progression of death. The response rate was significantly higher with cabozantinib 18% compared to 6% in the placebo group. And the survival was also numerically higher, so 43 months compared to 31 months with placebo. So here are my summaries for the CONVENT study. So cabozantinib significantly improves progression-free survival in well to moderately differentiated neuroendocrine tumors. It's active even in patients who have received many previous lines of systemic therapy. And the adverse events are consistent with the known safety profile of cabozantinib. So what does this mean for treatment sequencing in our practice? Because this drug has activity in heavily pretreated patients, we generally reserve it for later on in the treatment journey, usually after the patients have received PRRT. So some unanswered question from the data I've shown you is the treatment effect of cabozantinib by primary site of tumor, by grade, by number of prior treatments, and ultimately we need better predictive biomarkers. So what about combining cabozantinib with immunotherapy with atezolizumab? So I'll show you here some of the data. So as we know, immunotherapy by itself with checkpoint inhibitors doesn't really work well in GI or pancreatic neuroendocrine tumors. There's also scientific and biologic synergy between checkpoint inhibitor immunotherapy and cabozantinib, and therefore this was the rationale for this phase 2 CABA-10 study. This was a basket trial, and we'll look at the data for the grade 1 and grade 2 GI pancreatic neuroendocrine tumor cohort, of which there are 24 patients, and also the cohort with grade 3 extrapulmonary neuroendocrine neoplasms, of which there was 9 patients. So the grade 1, grade 2 GEP-NET cohort, the response rate of cabo plus atezo was 16.7%, with a progression-free survival of 13 months. For the grade 3 extrapulmonary neuroendocrine neoplasm cohort, unfortunately, none of the patients responded to the combination, and the progression-free survival was only 2.7 months. So my take-home is that, unfortunately, adding atezolizumab immunotherapy to cabozantinib doesn't really lead to enhanced efficacy, so not better than doing cabozantinib by itself. So to conclude, I want to remind everyone that the treatment journey for neuroendocrine tumors is a marathon rather than a sprint. In a marathon, we can start out by running fast, but it doesn't mean we'll necessarily come out ahead. So this is where we really need clinical trials to help us answer these important questions, and I highly encourage everyone to participate in clinical trials. And as I've shown you in today's talk, there are many ongoing prospective clinical trials to help us clarify what's the optimal systemic therapy sequencing or combination approach for neuroendocrine tumors. We also need studies to help us develop better predictive biomarkers to guide treatment based on who's going to respond to which treatment. And finally, because the treatment landscape is so complicated, we really need a multidisciplinary team to develop the best individualized treatment approach for each patient. Thank you very much.
Hi, everybody. My name is Osman Ahmed. I am an interventional radiologist at the University of Chicago. And today I have the pleasure of speaking with you all about liver-directed therapies, which is essentially what I do, and as well as histotripsy. So interventional radiology or interventional oncology, they're sort of used interchangeably, are treatments that we perform in the liver. And we often do this for neuroendocrine cancer patients. So one of the questions I get frequently asked is, why is the liver a common organ that is treated by interventional radiologists? And the reason is that the liver is very unique for a few reasons. One, it is incredibly resilient. So it has the ability to repair and regenerate itself, especially if it receives insults. So even, things like alcohol or trauma, the liver can repair and regenerate itself. But even, with the treatments that we perform, where we can actually attack the liver, the normal liver has the ability to sort of repair itself. In addition, the liver is also very unique because it gets blood flow from two different sources. One is the artery, just like most other organs get blood flow from the artery, but it also gets blood flow from a large vein known as the portal vein. And that will be important for a few different reasons. But first, let's start with what are the treatments that we can perform in interventional radiology for our neuroendocrine cancer patients. There's really two main types of treatments for the liver that we perform from an interventional approach. One type of therapy are known as transarterial therapies, where we actually go through the arteries and using X-ray guidance can deliver materials to tumors. And then the other is a more direct approach, and this is known as percutaneous ablation, where we're actually directly placing a needle inside of a tumor. And we'll talk about both of these. But let's first start with transarterial interventions where we're going through the arteries. And so transarterial interventions, what we're trying to do is we're actually trying to just shut the blood flow down to the tumor. And that term or concept is known as embolization. Just now, we talked about how the liver is very unique in that it has two sources of blood flow. One is the portal vein, and then in the normal liver, about 3/4 of the blood flow is from the portal vein, and about 1/4 of the normal blood flow in the liver is from the hepatic artery. What's very unique about tumors in the liver, and specifically neuroendocrine cancer tumors, is that the blood supply is primarily from the hepatic artery, about the reverse. So about 75 or 80% of the blood flow is actually from the artery itself. And so therefore, if you can do embolization or shut down the artery flow to the tumor, you can preferentially kill the tumor without really damaging the normal liver. And so this is kind of a cartoon schematic of what's kind of happening is we can take a very small tube or catheter all the way up to the tumor, and we can inject a variety of things. And depending on what we inject is the name of the type of embolization. So if we inject just regular beads or particles, that's known as bland embolization. And we can use really, really small particles, as small as 40 microns. And just for reference, the capillary is about 5 to 10. So it can get very down to the tiniest arteries to the tumor. However, if we inject chemotherapy, that's known as chemoembolization. And you can inject a variety of chemotherapeutic agents like doxorubicin, cisplatin, mitomycin, irinotecan. And then we can also inject radioactive microspheres, and that's known as Y90 or radioembolization. But these are all based on the same principle, which is to take a very small catheter all the way up to the tumor. So this is how this sort of works in real life. So this is, again, a cartoon schematic showing how most of this tumor is actually getting blood flow from the red vessel, which is the artery. And this is what it looks like in a CT scan. You can see here there's one nice big artery going to that sort of Death Star looking tumor. And this is what it looks like on an angiogram. So that was what it looks like in a CT. But when I do this procedure, this is what an angiogram looks like. So where we take the catheter, we get it all the way up into the artery, and you can see that there's clearly one artery kind of going and feeding this tumor. So we get a very small catheter all the way up into that artery. And once we're up there, then we can do whatever we want to do. So if we want to inject those particles and do bland embolization, we can do that. If we want to inject radiation, we can do Y90 or radioembolization, we can do that as well. But the technique is the exact same. So oftentimes what we're asked is like, well, a lot of what you do, that seems to compete with surgery, because should I have a surgery or should I have one of these therapies? The reality is that we actually work very well or complementary with surgery. Specifically, we kind of work hand in hand, especially at our tumor boards, to sort of decide what is the best option. And so oftentimes, if surgery is more appropriate, we go with surgery, but it's not uncommon where surgery is not an option. So one example would be there's too many tumors in the liver to go in and remove. Whereas to do a transarterial therapy, for example, where you could blanket all those tumors, that then would make more sense. We also oftentimes sort of work hand in hand with surgery as a combination strategy. So I'm going to show you a few examples of where surgery is very effective in clearing about 90 or 95% of the tumor. But then, we kind of come in on the back end to kind of clean up the rest or clear the rest. So here's a first example. This is a 60-year-old male who had a small bowel neuroendocrine cancer metastatic to the liver. And so the first step in approach to this treatment was to do a small bowel resection, to do a liver wedge resection, so try to get out as sort of the bulk of the tumor, and also take out the gallbladder, cholecystectomy. However, the patient underwent after surgery a follow-up MRI. And on this follow-up MRI, you can see there's some residual tumors left in the left lobe of the liver. So there's one there. Here's another slice. You can see there's actually 2 tumors here. So just to review, this patient has multiple small residual tumors in the left lobe. As you can see, there's probably maybe 4 or 5 tumors there. From an interventional perspective, since there's many lesions, more than 3 as I like to define that, we're going to try to target these tumors from an intra-arterial approach, because it would take a lot of time, effort to put 5 needles into those tumors. With this approach, where we actually go into the hepatic artery, into the liver, we can sort of from the inside treat all of those tumors at one time. And the goal would be to basically try to starve the tumor of its blood supply and kill or shrink the tumor. And so that procedure, as we just talked about, is known as bland embolization. So we're going to inject these plain or bland beads. And what we're going to try to do is cause an ischemic effect. Ischemic means to basically starve it of its blood supply. And so when you do that, the tumor, again, gets most of its blood flow from the hepatic artery, will basically necrose or die, and will be able to either shrink or kill these tumors. And as we talked about, we can inject beads that are as small as 40 microns, so very, very, very small beads to get really, really deep into the tumor and really kind of get a good tumor kill. So this is another picture of an angiogram, and this is the angiogram for this patient. You can see these are the hepatic arteries. So the catheter is actually in the artery that feeds the whole liver. And what I'm pointing out here with the circles are actually those tumors that we saw in the MRI. So this is what that looks actually like, an angiogram. So now what we need to do is actually go, so this is into the whole liver. We need to go into just the left side of the liver. So these are those left lobe tumors that we saw in the MRI. So what we're going to do is we're actually going to go into the left lobe of the liver. And you can see here we have a very tiny catheter here that's into that left lobe or the left hepatic artery. And from this position, we can proceed with our bland embolization, where we're going to inject these beads and really try to shut the blood flow down. And you can see here, here's a repeat angiogram, and there's no more flow to that left hepatic artery. So this is what we're going to do, is try to shut that blood flow down. And you can see here on the follow-up MRI, before these tumors were lighting up like light bulbs because they got their blood flow from the hepatic artery, and now the light bulb has burned out. So there's no blood flow there, so that's a dead tumor right there. And then what was interesting on this patient was where all those other little tumors were, we actually didn't see those tumors at all because they were so small that once we killed them, they basically disappeared. So they completely were obliterated. So we're really, really happy with this effect. And so working with surgery, we were able to sort of clear this patient's liver of tumor. So here's another example. This is a patient who had a pancreatic neuroendocrine cancer, and he underwent a pancreatectomy and a splenectomy. So they removed the pancreas and the spleen, and then also underwent partial liver resection as well as some intraoperative ablation of tumors. So they did a really, really extensive, excellent surgery. However, on the follow-up scan, there was just one single little tumor left in the liver. So the patient was referred to us to manage that single little tumor. So you can see here on this, there's one little tumor that's lighting up like a light bulb. And all these other little black spots, these are the tumors that were already killed at the time of surgery. So we just have one little tumor left, and these are the dead tumors from surgery. And so it would be kind of overkill to bring this patient back to the operating room and kind of go after that little thing. So we complement surgery very well here, I think, by doing a touch-up and just getting that last little tumor. And again, since it's only one tumor, unlike the other patient who had multiple lesions, we're going to do a more targeted treatment where we're actually just going to take a needle and put it into that tumor and kill it that way. And that procedure is known as percutaneous ablation, where we put that needle in there, and depending on what we do, so the most common type of ablation is known as thermal ablation, and we divide thermal into heat, so we can either do RFA, radiofrequency, or microwave. More often than not, we do microwave. If we want to freeze a tumor, that's known as cryoablation. And then if we want to electrocute the tumor, that's known as IRE. So what we decide really depends on a couple different factors that's not really important to talk about today, but knowing that we have a bunch of tools available to us to do that. So you can see here on this patient, this is the CT scan. So just like on that MRI, you can see the little tiny tumor there lighting up like a light bulb. And so what we're going to do is we're going to just go ahead, and I wish it was this easy, but you can see the needle has now been placed into the target. So the needle is perfectly within that tumor right now. And we're going to connect it to the machine, and we're going to go ahead and burn this one away. So this is called microwave ablation. And so before you saw that tumor looked like a light bulb, and now you can see here after just 5 minutes of burning it, we've created a nice big cavity of dead tumor. So this patient did very well, and then 2 years later came back, unfortunately, had an MRI that showed another new single liver lesion. And again, you can see here, kind of close to the old one, but in a different spot. A new tumor that's a little bit bigger, but it's still small. So 3 centimeters is kind of our cutoff. And so the same thing, kind of thoughts through our head was, again, we only have a single lesion here. It's very small. It's 3 centimeters. And again, it would be probably overkill to go back to the OR to treat that surgically. So we're going to go ahead and proceed with another percutaneous ablation. So this is just a rinse and repeat type of situation. You can see here, there's a tumor on the CT. Here's the needle in the target. So it's very similar. Get the needle in there. And then you can see here, this is after a 6 or 7 minute ablation. You can see here, it's no longer lighting up. It's just a dead cavity right there. And then this is on the follow-up. You can see here, this is a very tricky spot. It's in between some blood vessels, but we're still able to thread the ablation needle in there and burn that tumor away. So we're going to finish just talking about histotripsy a little bit because there's been a lot of excitement and questions, enthusiasm about it. So histotripsy is a non-invasive and a non-thermal method of ablation. So it doesn't need heat or cooling to kill the tumor. And the way it's non-invasive is that it actually uses ultrasound to create cavitation to a focal area. It is FDA approved for liver ablation, and we are actually one of the few centers in the country right now that has the commercially available unit, which is known as the Edison device. This is what histotripsy is actually doing. It's basically creating a cavity non-invasively. It's creating like as if an asteroid hit this liver and basically obliterating that area, kind of creating a liquefied homogenate there. This is what it looks like. This is one of the first procedures we ever did. This is the histotripsy actually in action. You can see here on the left, we're using ultrasound to identify the tumor, and then it's basically shooting the focused or targeted ultrasound to that red sort of bullseye area there. And this is what it looked like after the treatment. You can see here, just again, the light bulb has been burnt out, so we just see a black cavity there. And what's very interesting is this patient had a blood vessel almost running through the tumor, and histotripsy selectively only kills tumor. It's very protective to blood vessels, bile ducts, and that's another reason there's a lot of excitement around it. And you can see here, there's actually just a blood vessel running right through it, and it wasn't really impacted at all by the histotripsy. So the appeal for histotripsy is that it's completely non-invasive. It's robotic, so it's very precise. We basically draw a circle of where we want the histotripsy to kill or target, and the robot will essentially do it in an automated fashion. It's non-thermal, so we don't have to worry about burning or freezing critical structures that might be close by, like blood vessels and bile ducts. And it's also a single session therapy. In addition, there's no radiation, like we just talked about. This is all ultrasound based. You can treat multiple tumors at one time. Again, just like ablation, we like to treat up to probably 3 tumors. And it's also a platform technology. It's not just meant for the liver. It can actually treat other organs like the kidney, which there is a actual study, a human study underway, pancreas as well, prostate, and soft tissue. These are all have already been described in either animal studies or human studies. This is the actual Edison device with a cheesy picture of me standing in front of our unit. And this is from a procedure we actually just did very recently. This is the sort of the new clinical version, the one that's FDA approved. Looks a lot more sleeker than the original one that I showed you. And you can see here, it's all very nice touchscreen, kind of like an Apple iPad, and then the robot there over the patient. This is what it's actually doing. So the ultrasound is basically held outside of the patient or just robotically placed right above the patient. Once you target the tumor, you can actually see it focuses ultrasound and creates this bubble cloud that basically creates cavitation within the targeted area and mechanically destroys and liquefies the tissue. With that said, there's still much to do. Histotripsy is not, fully ready for prime time where we can treat every single patient. Since it utilizes ultrasound to target tumors, you have to be able to see the tumor under ultrasound through the water bath that you can see here on the left side. So it is limited to tumors that we can mainly see under the rib cage because the ribs block the ultrasound. So not everybody is eligible, and only a small percentage of patients right now are eligible. In addition, it's a new technology with limited data, so we're still learning where it's best utilized for. With that said, it's very exciting, and I think there's a lot of opportunity to develop the technology further. So I'll conclude by saying interventional radiology utilizes imaging techniques to help kill tumors in a very minimally invasive way. Everything that we do, pretty much, we just put a Band-Aid on at the end, and patients either go home the same day or the next day. And as we talked about, you can treat tumors of the liver through the arteries, which is known as embolization, or directly putting a needle into the tumor, and that's known as ablation. This works very well with surgery to help clean up things if there's any tumors left behind, or for patients who might not be eligible for surgery. And then, as we just talked about, histotripsy has a lot of promise as a new non-invasive method of ablation. So we're going from minimally invasive now to hopefully even completely non-invasive for some of our patients. So I'll finish here. Always happy to answer any questions. You can reach me through social media, or you can always ping me via email as well. Thank you so much.